Liver transplantation. Liver transplantation is used to treat life-threatening end-stage liver disease for which no other form of treatment is available. The transplantation procedure involves total removal of the diseased liver and its replacement with a healthy liver in the same anatomic location. That is orthotopic liver transplantation, OLT. Removal of the liver leaves a space for the new liver and permits anatomic reconstruction of the hepatic vasculature and biliary tract as close to normal as possible. The success of liver transplantation depends on successful immunosuppression. Immunosuppressants currently in use include cyclosporin, corticosteroids, azathioprine, mycophenolate mofetil, OKT3, a monoclonal antibody, tacrolimus, sirolimus, 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 as rapamycin, and anti-thymocyte globulin. Studies are underway to find the most effective combination of immunosuppressive agents and to identify new agents with fewer side effects. Surgical procedure. The donor liver is freed from other structures. The bile is flushed from the gallbladder to prevent damage to the walls of the biliary tract, and the liver is perfused with a preservative and cooled. Before the donor liver is placed in the recipient, it is flushed with cold lactated Ringer's solution to remove potassium and air bubbles. Anastomosis, that is connections of the blood vessels and bile duct, are performed between the donor liver and the recipient liver. Biliary reconstruction is performed with an end-to-end anastomosis of the donor and recipient common bile ducts. A stented T-tube is inserted for external drainage of bile. If an end-to-end anastomosis is not possible because of diseased air or absent bile ducts, an end-to-end anastomosis is made between the common bile duct of the graft and a loop, that is Rox NY portion of jejunum. In this case, bile drainage will be internal and a T-tube will not be inserted. Liver transplantation is a long surgical procedure, partly because the patient with liver failure often has portal hypertension and subsequently many venous collateral vessels that must be ligated. Blood loss during the surgical procedures may be extensive. If the patient has adhesions from previous abdominal surgery, lysis of adhesions is often necessary. If a shunt procedure was performed previously, it must be surgically reversed to permit adequate portal venous blood supply to the new liver. During the lengthy surgery, providing regular updates to the family about the progress of the operation and the patient's status is helpful. Complications. The postoperative complication rate is high, primarily because of technical complications or infection. Immediate postoperative complications may include bleeding, infection, and rejection. Disruption, infection, or obstruction of the biliary anastomosis and impaired biliary drainage may occur. Vascular thrombosis and stenosis are other potential complications. Bleeding is the common in the postoperative period and may result from coagulopathy, portal hypertension, and fibrinolysis caused by ischemic injury to the donor liver. Hypotension may occur in this phase secondary to blood loss. Administration of platelets, fresh frozen plasma, and other blood products may be necessary. Hypertension is more common, but its cause is uncertain. Blood pressure elevation that is significant or sustained is treated. Infection. Infection is the leading cause of death after liver transplantation. Pulmonary and fungal infections are common. Susceptibility to infection is increased by the immunosuppression needed to prevent rejection. Therefore, precautions must be taken to prevent nosocomial infections by strict asepsis when manipulating arterial lines and urine, bile, and other drainage systems, obtaining specimens and changing dressings. Meticulous hand hygiene is crucial. Rejection. Third complication. Rejection is a key concern. A transplanted liver is perceived by the immune system as a foreign antigen. This triggers an immune response, leading to the activation of T lymphocytes that attack and destroy the transplanted liver. Immunosuppressive agents are used long term to prevent this response and rejection of the transplanted liver. These agents inhibit the activation of immunocomponent competent T lymphocytes to prevent the production of effector T cells. Corticosteroids, azathioprine, mycophenolate meftil, rapamycin, anti-thymocyte globulin, and OKT3 are also elements of the various regimens of immunosuppression and may be used as the initial therapy to prevent rejection or later to treat rejection. Liver biopsy and ultrasound may be required to evaluate suspected episodes of rejection. Retransplantation is usually attempted if the transplanted liver fails, but the success rate of retransplantation does not approach that of initial transplantation. Thank you.